Okay. Anyway, this recording I am not using it. I am sending you to
Sir. Sir, you are not audible.
side. They are going to irritate the eyeball. They are going to irritate the cornea, giving rise to injury to the cornea. So we have to keep that also in mind whenever you see the eye. Then in the eye, after the conjunctiva or the white of the eye, that is sclera, we can see sclerocorneal junction. This is what we call as a sclerocorneal junction. From here onward, blood vessels will not enter into cornea. So cornea is transparent. So the cornea is transparent. So cornea is transparent. Okay. And then we see it is more bulging outside. Then you can see the color of the eye is because of the iris. Okay, color of the eye is by the iris. Iris is a diaphragm which controls the amount of light going inside and coming out. And then aperture in the iris, we call it as the pupil. Aperture in the iris is called the pupil. Now, before going proceeding ahead, some few points about the eyelids. Okay, what you know, eyelids. This eyeball is surrounded by the orbicularis oculi, correct? If you touch your eyelids, you can feel something is hard felt in the eyelid. That is something called as a tarsal plate. These are the fibroelastic plates inside the eyeball, inside the iris, inside the lid, and this will help to give a shape to the eyelid, and this also helps in the movements of eyelid. Lower eyelid will not require extra muscle because lower eyelid will open just by the gravity, but upper eyelid requires to be pulled up, and that's why there is levator palpebri superioris muscle. There is a levator, so that what it pulls, the levator palpebri superioris muscle pulls the superior tarsal plate. There are a lot of words, just listen to them as we'll go ahead and I say this section. Now another thing is why I want to emphasize. If you see the eye, we can see on the two extremes of the eyeball. One is on the lateral side and one is on the middle side. On the lateral side is called lateral canthus. It is called the lateral canthus. And this bulging on the middle side seen is called middle canthus. It is also called as a middle canthus. And the middle side, okay, do you remember where lies the lacrimal gland? Lacrimal gland lies on the lateral surface, lateral upper side. That is what the lacrimal fossa we talked about. And the gland, what is the importance of this lacrimal secretion? This lacrimal secretion helps in keeping the eyeball moist. How it keeps it moist? Most important thing is it has been every time brushed away by the blinking of our eyes. So our eyelids will help to spread the tear film and make a good tear film on the surface. Basically, tear film has various role to play. One role to play is that keep it moist. Second thing, as the cornea is avascular, it gives supply to outer one third of nutrition to outer one third of the cornea by the tear film. So this is another function of tear film. And this tear will every time when the eye blinks moves from upper lateral to middle side. And here there are two small openings. Can you see these two openings? So they are called punctures. They are called punctures. So what happens? The tear film which form every time eye blinks, that older tear film which has also collected some amount of dust particles and microbes will be washed away on this side. And it goes into the puncta, and from puncta it joins to the canaliculi and comes into lacrimal sac and finally drains into the inferior concha, drains into the inferior meatus. And that is why it happens that whatever the tear is formed throughout the day doesn't come out from the eyelid. What happens? It goes into the puncta, drains into canaliculi, comes into the sac, and finally drains into the nasal cavity. That is the reason whenever we cry, what happens? That whatever fluid is there, That fluid will come here, will be drained into this, and will come into. That's why our running nose starts whenever we cry also. Why? Because there is this fluid comes into here. Normally this fluid comes here, doesn't come out from the eye. There is a condition called extropia or entropia. That's what happens, that the fluid can come because of, okay, that is the part of that. So this is a lateral canthus, middle canthus. One more thing I want to talk about. Can you see this two ligaments? They are check ligaments, palpebral ligaments or check ligaments. Why they are there? They will prevent extra rolling of the eyeball, so that it will not be moving backward. That is what is there. Then we'll talk about now. If I take a sagittal section, what I see in that, we'll start from outside. Outside, we see the eyelid. This is what we are talking about. The outer membrane surface is covered by the skin. Inside there are muscles. Most important, this is a tarsal plate. This is tarsal plate and the modification of sebaceous and sweat glands that we'll talk in the lid. One more important, what I want, then there are the eyelashes. And then as I go inside, can you see this white color? This is a conjunctiva. This is a conjunctiva. We call it as palpebral conjunctiva. This is what we call it as the palpebral. See the palpebral conjunctiva lining the inner lining of the eyelids, and then as it turns around and reach up to the cornea, this is what we call as the bulbar conjunctiva. So bulbar conjunctiva is covering on the white of the eye. It doesn't go over the cornea. That is what you have to remember. Now you see the extra bulge. You see two parts. This bulge is a cornea. This bulge is a cornea. Then there is a gap here. Then there is an iris. See, the iris moves. So it is a circular structure, and the aperture between the iris is called the pupil. Then we see the lens, and you see the amazing fact about the lens. The lens is suspended. Lens is suspended. These are called suspensory ligaments. They are called suspensory ligaments. See, lens is dividing the eyeball into two different cavities. One in front of the lens, another is behind the lens. We're going to talk about that in the next slide. So that's what we remember. Then you can see the three layers as we go ahead in next slide. You can see here very clearly. We are remove the eyelids. Now we can see the bulging of the cornea. Why there is a bulging of cornea? This bulging of cornea is uniform. Now I will talk some about applied. That's why I'm talking about the bulging of the cornea is uniform, both in horizontal as well as in the vertical direction. So cornea acts as a larger lens. Remember, cornea acts like a larger lens. Whenever the light falls on it, it gets converged. It converges. Okay. Okay. So what will happen? That whatever the image is going to form, it should be at one point. Okay. Why? Because the curvature, horizontal curvature and vertical curvature should match each other.
So there is doubling of sound.
Yeah, I can understand. Is it different now?
No, sir, it is doubling.
I don't know. Okay. How? Okay, so cornea has a horizontal, vertical. Motion. Has a vertical and horizontal diameter. This should match. Oh, everybody is getting double sound.
Yes, sir.
Helpless.
Sir, somebody is not mute. That's why there is echo.
If anybody is unmute, please mute it. That is what I can request. No, otherwise, just I will leave the lecture. That's it. Okay. Are you able to listen now? So again, somebody has done the same thing. Roll number 22. Okay. So cornea has a horizontal diameter and a vertical diameter. So they will make a single image behind. But what will happen if the corneal diameters are different in horizontal and vertical? the image formed by the horizontal lens will be at a different level, and the image formed by the vertical diameter will be at a different level. And that is a condition, we call it as the astigmatism. So astigmatism is due to the irregular curvatures of the cornea. That is what we have to remember. Astigmatism is due to the irregular curvature of the cornea. That is what we have to remember. Which type of lens? If anybody has specs, we always see two types of lenses are in specs: cylindrical and spherical. The cylindrical lenses are basically to correct the astigmatism. That is what we have to remember. So cornea is related with the astigmatism. We can also correct this curvature by LASIK surgery or the laser surgery. So we can correct the corneal curvature. That is what is done in LASIK surgeries. Okay. Then we see the second layer. This is sclerocorneal junction. This is a sclerocorneal junction. Here we can see some opening. This is called the canal of Schlems. This is what we call as a canal of Schlems. Then what is this importance? We'll talk about. Then you can see the iris, which is a diaphragm, which has a muscle and highly vascular, which is an extension of this middle layer that is called choroid. Choroid extends further here to form a bulge just at the level of lens. It is called the ciliary body, and then it extends in front of the lens to form the iris. So iris, ciliary body, and the choroid are an extension of arytenoid matter. That's why it is highly vascular. That's why it is highly vascular. Then we see the ciliary body use a suspensory ligaments which hangs the lens. Lens, what is lens basically? Lens is a jello bag. Lens is a jello bag which has an anterior capsule, which has a posterior capsule, and it contains the cells like in a semi-liquid form. So whenever the lens is stretched, the focal length goes away. When the lens is relaxed, it becomes more globular, and once the lens has become more globular, then the focal length comes. That is near vision. So lens helps as a what we call the organ or the which helps in accommodation. Lens helps in the accommodation. What happens to this lens? Remember, this lens, as the age advances, reduces its hydration. And as the age advances, it reduces the hydration, the flexibility of lens is reduced. Flexibility of the lens is reduced. So what will happen? It will not get, whenever the suspensory ligaments are relaxed, it will not get bulged up. So the focal length, what is our normal focal length? Usually we see the 12 inches, that is 30 centimeters. That is where we keep the book and read it. It's the most ideal thing. Okay, but as the age advances, person starts putting the reading material away from his eyes. Why? Because his lens is unable to get bulged up because loss of its hydration, elasticity. So what will happen? The focal length will go apart, away, and that is what we call it as presbyopia. That is what we call it as the presbyopia as it age advances. So remember, astigmatism reduced to cornea. Presbyopia is due to the problem in lens, that is presbyopia as the age advances. It is said that after 40 years, every 10 years, our lens loses the dioptric power by 1. And that is how we start putting the near vision lenses. Okay, this is the most commonest thing. That is what happens with the, that is called presbyopia. And hypermetropia myopia is basically because of the diameters in lens of the eyeball. So there's what? So the astigmatism, presbyopia. There is a word. Another thing, lens as the age advances starts getting too much dehydrated, starts getting opaque. Okay, so that one thing. So now this is what. Now behind the lens there is a fixed amount of jelly-like substance we call vitreous humor. That is what we call as a vitreous humor. And now you can see this yellow color. This is a retina. This is a retina. Well, first thing we'll start, the retina abruptly ends here. Abruptly ends here. And where the retina ends, it is called ora serrata. It is called ora serrata. That is a word which is used. And as I go behind, retina is having all the nerves. So retinal nerve fibers, which forms ultimately the optic nerve. See, remember, these nerve fibers are converging at one place and going outside. So this is a place where there is no sensory receptors. And that is what we call as a blind spot. So from where the optic nerve comes out, that is a blind spot. This is called macula also. And another thing, through the optic nerve, a artery goes that is called central retinal artery. See, this central retinal artery is there, and then it is supplying the inner one third of the retina. It is supplying the inner one third of the retina. So from where it is going inside, this is one of the weakest part of the eye. We are going to talk what is its importance, but just remember here. So this is called the macula, and there is another cone here. Can you see this? This cone contains maximum amounts of rods and cones. Sorry, cones. Maximum amount of cones. So here there will be acuity of vision or maximum sharpness of vision is there. That is what we call it as a fovea. So remember these two terms. Macula is different. Fovea is different. Macula is the place where the nerve fibers of nerve exits out. So there are no sensory cones or rods. So that's why it is also called as a blind spot. It is also called as the blind spot. And at the blind spot, we also see the blood vessel. That is what we see from the eye. Whenever we want to check this, we put a fundoscope here and we see inside the eye. And we can see this macula because whenever the pressure increases, increase in ocular pressure, we call it as glaucoma. This is the weakest part, so this gets compressed. And because it gets compressed, it causes more of a cupping. And that's what we call macular cupping. That is what we call as a macular cupping. What is macular cupping? Is a blind spot getting depressed. Why? Because there is increased pressure in the eye. Why? It is a concept called as glaucoma. That is what we call as a glaucoma. But how it happens, we'll talk about later. Then there is a maximum number of cones here. That is what we call as the fovea, where the maximum acuity or sharpness or crispy image is formed. That is what we call as a fovea, where maximum number of cones are there. And as I go in the periphery, here there will be more rods, and slowly the number of rods will reduce inside as we go in the periphery. That is what we have to remember. It will aid retina ends, and that end is called ora serrata. Now, so we have seen the outermost layer is a tough structure, middle layer is a choroid, which extends forward to form the ciliary body. Ciliary body has two important structures. One is muscles, 3 layers of muscles, and the ciliary body here at this level secretes the aqueous humor, that is liquid-like fluid. Posteriorly, there is vitreous. Anteriorly, there is aqueous humor, which will be secreted here, which will flow from the in front of lens and will come in the anterior part, and then it will be absorbed by the canal of Schlems. How? And then muscles, what they do, they just see that these muscles we are showing in the only in the 2 dimension, but remember they are from the all the sides. They are from the all the side like this. All ciliary muscles are there. So whenever they will contract, what will they? Ciliary muscles. I am talking about the ciliary muscles. What they will do, whenever the ciliary muscles contract, they will come near to each other. They will come near to. What will happen? There are suspensory ligaments. See, ciliary muscle is relaxed. Suspensory lens is here in between. Now, when the ciliary muscle will contract, the suspensory ligaments will relax. And when the suspensory ligaments will relax, this jello-like bag of the lens will bulge. And when the jello-like bag of this lens bulges, it reduces the focal length. It reduces the focal length. That is what we call nearsightedness. That is what we see the object while reading. Okay, and reverse occurs when I see in the infinity. What will happen? The ciliary muscles relaxes. Ciliary muscles relaxes. When the ciliary muscle will relax, suspensory ligament pull. Suspensory ligaments are pulled, the lens become more flattened. When the lens becomes more flattened, the focal length goes away. That is what we see that at a distance. This is what we call the process of accommodation. That is what we call as a process of accommodation. You have to listen this point once, twice, thrice when I will set the recording, and you will get idea. What you have to remember, ciliary muscles, when they contract, they relaxes the suspensory ligament. They relaxes the suspensory ligament of the lens. The lens becomes more bulge, more globular, biconvex lens. The focal length comes near. When the ciliary muscle relaxes, the suspensory ligaments are taut up. They will be stretched. And when the suspensory ligaments stretch, lens become more flatter. And once the lens become more flatter, that makes the focal length to go away. Okay. And what I said, that as the age advances, the elasticity of lens has reduced. It becomes more rigid. So it is unable to get more globular. And that is the reason the focal length maximum nearest is 30 centimeters goes away. And that is why the older person read the thing by keeping the object away from it. That is what we call it as the presbyopia. That is what we call it as the presbyopia. Now, few concepts I want to just put it up. Now, this lens. Anytime you have gone to ophthalmologist and you may have read on this one his degree MS ophthalmology, and then sometimes it is done he is a posterior segment specialist. He is a posterior segment specialist, or some people will write he is anterior segment specialist. Even going further, he may write anterior chamber. So what does this word means? So I will just explain now. Once we know all these layers, all these parts of this one. So lens keeping in the center, from the posterior surface of lens till the retina, from the posterior surface of lens till the retina, we call it as posterior segment. We call it as, remember this term, posterior segment. Now, in front of the iris, it is called anterior chamber. In front of the iris, till the cornea, it is called anterior chamber. Behind the iris, till the lens, suspension ligament, is called posterior chamber. So remember, anterior segment is further subdivided by the iris into two parts. In front of the iris, it is anterior chamber. Behind the iris, there is a posterior chamber. Fluid of the anterior segment is aqueous humor. Fluid of the anterior chamber is anterior segment is, what is that? Aqueous humor. The fluid of the posterior segment is vitreous humor. This is one difference. Second difference, aqueous humor is like a CSF. It is produced in the posterior segment by the ciliary bodies. Flows between the lens and the iris comes into the anterior segment. Flows from the behind the surface of the cornea, reaches to sclerocorneal junction and gets reabsorbed here like a canal of Schlem's. Here there is a canal of Schlem's. If you remember, there is something like CSF. CSF is produced by choroid plexus. So choroid plexus is equivalent in eye as a ciliary body. The fluid has been drained, will be produced, that is aqueous humor. There the CSF is formed. It flows between this. This aqueous humor flows behind, comes in anterior chamber. And as we know, like from the ventricles, the fluid comes into subarachnoid space, and from subarachnoid space, it is reabsorbed by the arachnoid granulation. The same way, canal of Schlem's acts like arachnoid granulation. So the fluid is absorbed. Why I'm talking about this? Remember, this is continuously changing fluid. What is its basic function? Keeping the hydration of the lens, hydration of the this one, what we call as a cornea, maintain the ocular pressure. Why this ocular pressure is essential? Many times it question comes, why there is a need for keeping the ocular pressure? One of the reason is that eyeball, if it would have been empty, it would have been collapsed. So to keep the pressure maintained, this aqueous humor indirectly will keep the pressure on the vitreous humor. And ultimately, vitreous humor will maintain the shape and size of the eyeball. That is one. Second thing is that this retina is not tightly adherent to choroid beneath. It can be easily detached. It can be easily detached. So to prevent that detachment, the intraocular pressure has to be maintained. It should not be too low. And the reverse is true. If it increases, why? What can happen? Increase in formation of aqueous humor can be one of the reasons to increase the. Another is that this angle, can you see this very narrow angle is formed here, and this narrow angle will become too narrow so that the aqueous humor is not reabsorbed properly, again increasing the intraocular pressure. And increase in intraocular pressure is called glaucoma. Increase in intraocular pressure is called glaucoma. So a lot of ophthalmology, a lot of things. Astigmatism, presbyopia, cataract, glaucoma. These are the few conditions, and then refractive errors. That is what we talked about. So the aqueous humor is formed by the ciliary body. One function. Second function of ciliary body is to maintain the accommodation. To maintain the accommodation. Okay, so this is a basic brief view, and I can just talk about again. We can talk about cornea. This is the anterior chamber. This is the posterior chamber. You can see the suspensory ligament. These are the ciliary bodies. You can see the vitreous or posterior segment. From the lens up to here is the anterior segment. Anterior segment is further subdivided by the iris into posterior segment, chamber, and anterior chamber. This is a canal of lens. One more very nice figure is there. Just I will share with you. Can you see now this? You can see this is a posterior chamber. This is the anterior chamber. You can see the cornea. You can see the canal of Schlenz. Then you can see the sclero. So this is a sclerocorneal junction, and this is the angle from where the aqueous humor is reabsorbed. And if this is a narrow, use the angle closure glaucoma. It means the angle closure glaucoma. Then you can see the ciliary body. Ciliary body has extension. From here the aqueous humor is formed, and then you can see in the ciliary body there are muscles which helps in keeping this suspensory ligament in position. When they contract, they come near and they will relax the suspensory ligament, and you can see the lens will get what is the more globular, that is a near vision. So this would, and you can see the iris is richly supplied by the blood vessels. And you can see the two sets of muscle in the iris. This muscle is called constrictor pupillae, and this muscle is called the dilator pupillae. So remember, dilator pupillae will increase the aperture, constrictor pupillae will be reducing the aperture, so that amount of light entering inside will be controlled. So this is what we talk about, and then we'll talk about the vasculature. If you remember orbit, what do you remember in orbit? We talked about the central retinal artery, which goes through the optic canal with the optic nerve, which enters inside from the macula. And as it comes inside, it supplies the inner 1/3 of the retina. Okay, but what happens? Now see another arteries, that is what we talked about, long posterior ciliary artery and short posterior ciliary artery. Then we talk about anterior ciliary arteries, which are the branches coming from the muscle. They all will not go inside the retina. They will go into choroid, and they will form the choroid plexus. They will form the choroid plexus, and this choroid plexus is a rich vascular plexus, which will going in front, will be forming the ciliary body, helping in the formation of aqueous humor, and the same vessels will go into the iris. And will be, so iris is also highly vascular. That indicates this three vascular code: choroid body, ciliary body, and choroid, ciliary body, and iris are the extension of mesodermal origin, or that is what we call as the middle layer of the brain. That is this is sclera is the dura, and this is the arachnoid matter, and the cornea is set on this. Here there is a thin layer, that is what we call as pigmented cell layer. So retina gets a blood supply, dual blood supply, but major blood supply is coming from the central retina. Central retinal artery, if you see, it doesn't form any anastomosis. And that is the reason if the central retinal artery is compressed or closed, it causes loss of vision. It causes the loss of vision. Okay, that is what I just want to emphasize. So if you start to see here, this is a retina which can easily get detached. That is what we have to remember. Blood supply of the eyeball, central retinal artery, and then there will be short and long posterior ciliary and anterior ciliary. Venous drainage is by the ophthalmic veins, which drains into, where it drains, so remember, they drain into cavernous sinus. They drain into the cavernous sinus, and that is the reason whenever the cavernous sinus block is there, there will be back pressure, giving rise to reduction in the vision. That is what we talk about. So this is how I just want to emphasize how the eyeball is richly vascular, but disadvantage is that central retinal artery is not having any anastomosis. So we have to always take care of this central retinal artery. Diseases of eyeball: astigmatism related with the cornea, presbyopia related with the lens, cataract means the lens gets opaque. Now just I want to add a few points about the cataract. If the cataract opacity develops at the periphery, or the cataract opacity develops in the center, So that is called central cataract or peripheral cataract. How we can differentiate between this? In the daylight, if person says, because in the daylight the pupil constricts and the person says, I have reduced vision, usually it is related with the nuclear cataract. It is related with the nuclear or central cataract. If person says, in the day I am okay, but in the evening hours when my, or in the darker region, my vision suddenly drops down, indicating that because the pupil dilates, light is also coming going from the periphery, and if it is obliterated, that is called peripheral cataract. So this is what we have to remember. Cataract can be subdivided nuclear or the peripheral. Peripheral, person will say reduction in vision during dim lights or the evenings. And central cataract, there will be a loss in the daytime because there is a central cataract, central opacity. Even in congenital cataract, usually it is nuclear because of rubella. So then we talk about the glaucoma. Remember, vitreous humor, once formed at the time of birth, will never change. That is what you have to remember. Aqueous humor is a continuously changing thing. It is formed at the ciliary body, reabsorbed at canal of Schlems. Aqueous humor decides the intraocular pressure. So whatever surgeries we do in glaucoma to reduce and increase the reabsorption, or either we get a drug which will reduce the formation of aqueous humor. That is we can control this one. Okay, another thing, wonderful things are there. We can put a tube from the cornea, just side of sclerocorneal junction, univalvular tube. When the pressure increases, the valve opens and the fluid comes in the conjunctiva. Conjunctiva is again a very good reabsorption surface, so it gets reabsorbed. So unidirectional tubes can be put here. That is valvular tube, small, very thin, cannot be seen by naked eyes. So from the lens to retina, it is a posterior segment. One more thing I want to talk about, whenever we remove the lens removal can be done by two ways. One is complete removal of lens, and nowadays we don't remove the lens. What we do, we just take an incision on anterior capsule. This jello-like substance has been mixed up, emulsified, and will be taken away, and the flexible lens can be put up here. That is what we do. That is what we call as IOL, intraocular lens fixation. IOL, intraocular lens fixation. Lens gets rigid as the age advances. It is called presbyopia. It is called the presbyopia. Glaucoma in local term is called Katz's bindu. Glaucoma in local term, when we go to the patient, it is called Katz's bindu. Cataract is called Moti bindu. Cataract is called Moti bindu. These are the few terms, and just I just talked about this. Next time we will be going to the histology of eyeball. Thank you. Thank you very much.